Welcome to your first online class for this course. In today's lecture, we'll attempt to cover Chapter 8, which involves compounding, Chapter 10, which is basic biopharmaceutics, Chapter 11, factors affecting drug activity, and Chapter 12, which is my personal favorite, information. Let's begin with Chapter 8. Extemporaneous compounding is defined in the textbook as the on-demand preparation of a prescribed drug product to meet the unique needs of an individual patient. Apparently, compounding is an art form that I do not personally possess. I typically live by the rule, I'd rather be lucky than skilled. In what situations do you think compounded medications are needed? Pediatric patients may require diluted adult strengths of medications. Some patients require a solution or suspension that is only available in other dosage forms. Patients may have sensitivities or allergies to dyes, preservatives, or flavoring agents found in commercially available products. Topical preparations may need to be created that have different strengths compared to what is available. Hospice patients may require unique products for pain management. You may need to prepare different versions or dosages of medications for animals. And the pharmacist must be able to determine if the product can be accurately compounded and stable for the expected use. Compounding and manufacturing are not the same thing. Here are the definitions of each verbatim. Compounding, by the definition presented here, refers to making a preparation based on a prescriber's order. Manufacturing refers to a commercial process. The state boards of pharmacy and the USP regulate compounding. The USP-NF standards are published in numbered chapters. Chapters with numbers less than 1,000 are legally enforceable by the FDA, and those with numbers greater than 1,000 are guidelines or informational chapters. Chapter 795 sets the legal standards for non-sterile compounded preparations. Chapter 797 sets the legal standards for sterile preparations. The USP established standards for quality, strength, purity, packaging, and labeling. USP sets personnel standards that give the pharmacist responsibility and the authority for managing the compounding area. There are standards on the physical design and maintenance of the compounding area. There are also standards on the purity of the ingredients. Quality assurance ensures the compounded formulation meets specifications and satisfies standards. Quality control is a set of testing procedures that determine the quality of the compounded formulation. There are packing and storage standards. Documentation and record keeping standards provide consistency when the same formulation is compounded multiple times. Stability is defined as the extent to which a dosage form retains the same properties and characteristics it possessed when it was made. Beyond use date is the date assigned to the compounded prescriptions beyond which the formulation should not be used. Manufacturers assign expiration dates. Pharmacies assign beyond use dates, which are much shorter and assigned to compounded products. Here's a list of definitions of different temperatures. I'll direct your attention to two major temperature ranges. Refrigerator temperature is 2 to 8 degrees Celsius, and controlled room temperature is defined as a range of 20 to 25 degrees Celsius. Each compounding process, measuring, mixing, molding, and packaging, has its own equipment. Measuring equipment includes balances, weights, weighing containers, and volumetric glassware. Mixing involves beakers, Erlenmeyer flasks, spatulas, funnels, and mortar and pestles. Molding includes hot plates, suppository molds, and capsule shells. Packaging involves prescription bottles, capsule vials, suppository boxes, and ointment jars. Class A torsion balances have a minimum weighable quantity of 120 milligrams with a 5% error. Usually, the maximum weighable quantity is 60 grams, but some will weigh up to 120 grams. A Class A torsion balance is a two-pan balance that uses both internal and external weights. The balance has a rider that adds the internal weights to the right-hand pan. Brass weights are used. These are stored in a box, and when removed and placed on the balance, you do not touch them. You use forceps. The product is weighed on the left pan. Before using a Class A balance, be sure to level the balance from front to back and side to side. Weighing papers or weighing boats are always placed on the balance pans before weighing. If someone asks you to tare the balance, it means to negate the weight of the weighing paper or weighing boat before adding drug. In this picture, you get an idea of what a Class A torsion balance looks like. as well as an analytical balance. The red box contains metric weights. They must be handled with forceps, not with fingers, to prevent soiling and erosion. Electronic or analytical balances are used for measuring amounts less than 120 milligrams. They have sensitivities of approximately 1 milligram. We have already alluded to the use of weighing boats and papers. They are used to place product on the balance. Mortars and pestles are used to mix solids and semi-solids. They are made of three types of materials: glass, wedgewood, and porcelain. The process of grinding powders into smaller particles is called trituration. Spatulas are used to transfer solid ingredients and can be used to mix semi-solid dosage forms such as ointments and creams. A term I don't hear that often is spatulation. This is the mixing of powders with a spatula. When it comes to measuring liquids, volumetric equipment is used. This equipment includes pipettes, cylindrical and conical graduates, burettes, syringes, and volumetric flasks. Always use the smallest device that will accommodate the desired volume of liquid. This will help reduce errors associated with misreading the scale. Avoid measuring volumes that are 20% or less of the capacity of the measuring container. The readings are inaccurate. For example, don't use 100 ml graduated cylinder to measure 20 ml or less. Oily or viscous material is difficult to remove from cylinders. It takes time for it to drain from the container. It may be better to use a syringe instead. Note, liquids have a meniscus when they are poured into a container. In order to read the exact volume, you have to be at eye level with the meniscus and read the mark at the bottom of the meniscus. So what causes a meniscus to form? The attractive forces between the container and the liquid is greater than the attractive forces between the individual molecules of the liquid. The liquid sticks to the container, so to speak. Before the next class, see if you can find what the opposite effect of the meniscus is and what substance may produce this opposite effect. Levigation is the technique used to reduce the particle size of a powder by triturating it with a solvent that does not dissolve the powder. Ointment slabs are porcelain or ground glass plates. They provide a hard, non-absorbable surface for mixing compounds. Let's dive into Chapter 10, Basic Biopharmaceutics. Drugs enter the bloodstream and travel throughout the body to their site of action. The goal is to deliver the correct medication in the correct concentration to the correct site of action at the correct time, leading to a desirable effect. The truth of the matter is, sometimes we get an undesired effect. Drug effects are produced when a drug interacts with a receptor on your body's cells. The interaction has been described by the lock and key model. The lock is the receptor on the cell, and the key is the drug molecule that fits the receptor. Only the drugs that retain the properties to fit the receptor can produce an effect. The receptors located on the cells are exposed to any drug that is present in the body. The lock and key model helps explain why drugs are selective. By modifying characteristics of drug molecules, scientists can target specific receptors and narrow down what tissue is actually affected by the medication. You can have one of two effects. Drugs can either activate or inhibit cellular functions. If the drug activates receptors, then it is an agonist. If the drug inhibits activity, then we call it an antagonist, which works by blocking a receptor, preventing other drugs or substances in the body from activating it. In order for a drug to produce an effect, a certain number of receptors have to be available to interact with the drug. Likewise, there has to be enough drug molecules around to interact with available receptors. Once a drug molecule occupies a specific number of receptors, an effect is produced. If there are not enough drug molecules, there may not be an effect, or the effect is minimal. This is when the dose has to be increased. Once the receptors are completely occupied, no further effect can be produced by that drug. Increasing the dose will not help. We say the receptors have been saturated. In a perfect world, we would have the capability to measure the exact amount of a drug at the exact site of action. This is a very complex issue because there are so many factors that affect the movement of the drug from the point of administration to the site of action. The amount of drug may be so small at the site of action that it's undetectable. Also, we may not have a clue where the drug is located in the body at the time of the effect. These reasons are why we determine the drug's concentration in the blood. Blood reaches equilibrium very quickly between the site of administration and the site of action. Consequently, Knowing the drug concentration in the blood can be directly related to its effect. When viewing a blood concentration time profile, there are some definitions to keep in mind. The minimum effective concentration, or MEC, is the lowest concentration at which a drug can produce an effect. Minimum toxic concentration is the lowest concentration at which the risk for undesirable effects is increased. Onset of action is the time that it takes for the minimum effective concentration to be reached and an effect to be produced. The range between the minimum effective concentration and the minimum toxic concentration is referred to as a therapeutic window. When blood concentrations are within the therapeutic window, patients are typically receiving maximum benefit from the drug with minimum risk. How long the drug concentration stays above the minimum effective concentration is referred to as the duration of action. In Chapter 1, we introduced the term pharmacology. When it comes to the factors that determine blood concentration of the drugs, we're going to look at pharmacokinetics, which is what body does to the drugs. There are 4 processes that make up pharmacokinetics, and we call them ADME: absorption, distribution, metabolism, and excretion. Absorption refers to the process that transfers a drug into the bloodstream after administration. Absorption is the primary process of the first part of the blood concentration time curve where concentrations rise. One of the major factors that affects oral drug absorption is gastric emptying time. This is the amount of time the drug will remain in the stomach before it is emptied into the small intestine. Remember, most drug absorption occurs in the intestine, and stomach acid can degrade many drugs. Consequently, the longer the drug remains in the stomach, or the longer the gastric emptying time, the less likely the drug will make it to the small intestine for absorption to take place. The route of administration affects absorption as well. It can affect the extent of absorption as well as the rate of absorption. Intramuscular injections take longer to absorb than intravenous injections. The textbook points out that distribution involves the movement of a drug within the body once a drug has reached the blood. Factors that affect distribution include 1. Blood flow rates. The heart, liver, and kidneys have high rates of blood flow, so drugs are rapidly distributed to these organs. Muscle, fat, and skin have lower rates of blood flow, so distribution is slower. Tissue permeability is a factor as well. Small molecules and lipophilic molecules, or hydrophobic is what the textbook uses, diffuse through tissue membranes with ease. Protein binding also has an effect. If drugs bind to proteins in blood plasma, they form a large complex, which prevents the drug from entering its site of action, metabolism, and excretion. In essence, the drug has been rendered inactive. Only free or unbound drug can be distributed and produce pharmacological activity. Metabolism is the body's process of changing drugs. These transformed drugs are called metabolites. The majority of metabolites are inactive, but some metabolites can be active and produce effects until they are further metabolized. The liver is a major site of drug metabolism. Enzymes found in the liver transform drugs into metabolites. Metabolism and excretion combined are referred to as elimination. Kidneys are responsible for filtering blood and removing waste materials that include drugs and metabolites. Bioavailability is the amount of drug delivered to the site of action and the rate at which it becomes available. Bioequivalent drugs are pharmaceutical equivalents that have the same rate and extent of absorption when administered using the same dose under similar conditions. Here are some more definitions. Pharmaceutical equivalents are drug products that contain identical amounts of the same active ingredient in the same dosage form. Pharmaceutical alternatives are drug products that contain the same active ingredient but not necessarily the same salt form, amount, or dosage form. One example of this is metoprolol tartrate versus metoprolol succinate XL. We have actually already covered slides 38 through 40. They are in the slideshow for your reference. Now we'll take a look at factors that affect drug activity. Human variability can alter blood concentration time profiles and drug efficacy. Some human factors that come into play include age, weight, genetics, and gender. Listed here are definitions of ages. A neonate refers to a newborn up to 1 month. Infant refers to 1 month to 2 years. Between the ages of 2 and 12, you're technically a child. 13 to 19 is an adolescent. Adult years are 20 to 70, and elderly is anything above 70. The organ systems of infants and neonates are not fully developed. Consequently, drug distribution, metabolism, and excretion are quite different when compared to adults. Elderly patients have changes in gastric pH, gastric emptying time, as well as changes in the cardiovascular system and liver. Another big issue is the fact that kidney function declines as we age. Gender can play a role as well, and the textbook points out the differences can be attributed to hormones, weight, and the distribution of body fat among men and women. During pregnancy, women can have delayed gastric emptying and reduced intestinal tract motility, which will reduce the rate of absorption. The rate of urinary excretion for a number of drugs is much greater in pregnant women versus non-pregnant women. Your genes determine the type and amount of proteins produced in your body. Since medications interact with proteins, genetic variability can produce different drug actions. The text points out somewhere between 20 to 50% of human variability may be due to genetics. Because human variability exists, adverse reactions can occur in one person, but not another. Adverse drug reactions are unintended effects of the drug. Adverse reactions may affect any organ system. Patients may develop dizziness, sedation, agitation, or confusion. We're probably familiar with the effects of Tylenol on the liver. There is a difference between allergic reactions and adverse reactions. Allergic reactions are immune-mediated reactions to drugs. Adverse reactions can occur at normal doses or abnormal doses of medications and are typically related to the way the drug works. Patients often list medications on their allergy list even though the reaction was an adverse reaction, not an allergic reaction. This is detrimental to therapy. Sometimes patients list penicillin allergy because Augmentin gave them diarrhea. Clavulanic acid is known for this adverse reaction, which is an ingredient in Augmentin. When physicians try to treat future infections, they may try to avoid penicillins, cephalosporins, and carbapenems, all of which contain similar beta-lactam structures. GI effects are probably the most common adverse effects we see in patients. Nausea and vomiting are probably the most common of these. Some medications have direct effects on the kidneys. Vancomycin can damage kidneys. Aminoglycosides like gentamicin and tobramycin can cause reversible kidney damage as well as irreversible hearing damage. If you search in a dictionary for the word idiosyncrasy, you will find that this is a characteristic, maybe even a habit that is specific to an individual. I have an in-law whose idiosyncrasy is to contradict anything you say, even if you change your mind to agree with his. It's an expected or predictable characteristic of his. Idiosyncratic reactions, on the other hand, are counterintuitive. These are unexpected, possibly unexplainable reactions that occur for the first time a patient is given a drug. The thought is that idiosyncratic effects are due to genetic causes. Other undesired effects include blood clotting or bleeding, psychological and physical dependence, abnormal fetal development, which is referred to as the teratogenicity of a drug, and some medications can cause cancer. There are several different types of drug-drug interactions, and the potential for drug-drug interactions is directly related to the number of medications someone is taking. If two drugs have an additive effect, then they have similar actions that result in an effect that is equal to the sum of the individual effects. An example is amiodarone and Levaquin. Amiodarone is used in arrhythmias and can prolong a patient's QTc interval, but so can Levaquin, an antibiotic. Their effects are additive. If two drugs have synergistic effects, the combination of the two medications will lead to an effect that is greater than the sum of the individual effects. The textbook points out the use of vancomycin and gentamicin on the bacteria Enterococcus faecalis. The text says gram-negative, but it's actually a gram-positive bacteria. The reason these are synergistic is because gentamicin is not effective when used alone, but once vancomycin is added to the regimen, the effect of gentamicin is increased, so their effects combined are greater than the sum of the individual effects. Potentiation occurs when one drug with no activity of its own increases the activity of another drug that produces an effect. Augmentin is an antibiotic mentioned earlier that contains both amoxicillin and the actual antibiotic, and clavulanic acid, a substance that inhibits beta-lactamase, an enzyme that breaks down amoxicillin. The clavulanic acid potentiates the effect of the amoxicillin. Antidotes are drugs given to block or reduce the adverse effects of other medications. Naloxone is an example of an antidote. This is an opioid antagonist that blocks and reverses the effects of opioids. So if someone overdoses on morphine, which could lead to respiratory failure, they are given naloxone to reverse the effect. Also, vitamin K is given to reverse the effects of Coumadin. This is a very common scenario in the hospital. Other interactions may include a drug displacing another drug from binding sites on proteins. Remember, only unbound drug can produce an effect. So whatever drug is displaced during the reaction, that's the drug that will have its effect increased. Some enzymes are inhibited, which means that metabolism is slowed down and the effect of the drug will be increased. On the flip side, if an interaction leads to increased enzyme activity, then metabolism is increased and the effect of the drug is reduced. The processes that make up pharmacokinetics are affected by drug-drug interactions. Some drugs interact to form complexes that are not absorbed. An example would be di- and trivalent cations like iron and magnesium interacting with the antibiotic levaquin to decrease its absorption. Some drugs prolong gastric emptying time, which means the absorption of other drugs may be delayed. Also, some drugs are only active at certain pHs. If you take an antacid, the change in pH may reduce the effect of other medications. Distribution of a drug can be affected if it is highly protein bound through displacement. We alluded to this earlier. Only unbound drug can be active. Some interactions involve one drug displacing another from protein binding sites. The result is higher pharmacological effect for the displaced drug. We have already reviewed the concept of enzyme induction and inhibition. If enzymes are induced, then metabolism of drugs that use those enzymes will increase. The opposite is true for inhibition. Some drugs compete for the same transport system in the kidneys. When two drugs compete, this can cause one or both of the drugs to accumulate in the blood. This can be used as an advantage. Probenecid can be used to compete with and reduce the secretion of penicillins, leading to higher concentrations of antibiotics in the patient's system. NSAIDs compete with methotrexate, which causes the amount of methotrexate to increase in the patient, leading to methotrexate toxicity. What people eat can also play a role in drug activity. Just the presence of food can decrease the absorption of certain drugs. Another interaction that occurs is when patients eat green leafy vegetables that are high in vitamin K. Vitamin K is the antidote to Coumadin. If a patient goes from not eating these to eating them 3 times a week, then the effect of the warfarin can be reduced. Foods with a high tyramine content, such as red wine and aged cheeses, can interact with monoamine oxidase inhibitors, although these drugs are rarely used. If this interaction occurs, a hypertensive crisis may ensue. When tyramine reaches a certain amount in circulation, it displaces norepinephrine, which leads to vasoconstriction and increased blood pressure. Of course, dairy foods contain calcium, which can interact with levaquin, just like iron and magnesium. Damage to the liver, which can be found in patients with cirrhosis and hepatitis, can affect the metabolism of drugs. Liver enzymes that normally metabolize medications may be damaged, so the metabolism is decreased. Any scenario that reduces blood flow to organs affects drug absorption, distribution, and elimination, which can also affect drug activity. If patients have damaged kidneys, drugs that are renally eliminated may begin to accumulate. Doses are typically adjusted based on a patient's renal function. We have already talked about the information covered on slides 54 through 62. They were left in the slideshow for your review. Let's progress to the last chapter in this online presentation, Chapter 12, Information. As healthcare progresses, there's going to be more and more research done, and new drugs will be introduced to the market. In addition, new uses for already existing drugs will be discovered. I've found it difficult to keep up with every new drug that is going on in the pharmacy. But luckily, I've found several references that I use on a daily basis that allows me to find information quickly. The textbook points out that pharmacy literature can be thought of as a pyramid divided into 3 sections: primary literature, secondary, and tertiary. Primary literature includes original reports of scientific research. This provides direct access to the largest amount of current information. Secondary literature is a reference used to locate primary literature and consists of abstracts. Secondary literature mostly consists of general reference works based upon the primary literature. Tertiary literature sources contain condensed information based on knowledge established by primary literature. Tertiary literature should be reviewed carefully because authors may misinterpret the primary literature. As of now, there are no federal laws that mandate pharmacies to carry professional drug information literature. OSHA, Occupational Safety and Health Administration, requires pharmacies to have a material safety data sheet, abbreviated MSDS, for each hazardous chemical they stock. Most states, however, require pharmacies to maintain specific professional literature. Slides 68 and 69 have already been reviewed, but will be used for your reference. Drug Facts and Comparisons contains information about prescription and OTC medications that is presented in comparative tables. It is used to compare drugs in the same therapeutic class. The American Hospital Formulary Service contains comparative, unbiased, and evidence-based drug information. It groups drugs by therapeutic use. The USPDI Volume 1, Drug Information for the Healthcare Professional, contains industry-respected drug information, reviewed by more than 800 healthcare professionals. USPDI Volume 2, Advice for the Patient, is written in patient-friendly language. This respected reference explains drug information in easy-to-understand terms. Volume 3, Approved Drug Products and Legal Requirements, has all the information on the federal guidelines affecting drug prescribing and dispensing. The Orange Book is used to determine the therapeutic equivalence of a brand and generic drug. Drugs with Code A are considered equivalent, but Code B drugs are not equivalent. The Handbook on Injectable Drugs, often referred to as TRISLs, is a good source to find information regarding preparation, storage, administration, compatibility, and stability of injectable drugs. If you need to know the prices on prescription drugs, OTCs, nutraceuticals, and/or bulk chemicals, the Red Book is a source you need. The Physician's Desk reference contains info similar to the manufacturer's package insert. As far as online sources are concerned, I use Micromedics more than any other. I can find information on dosing and adverse effects as well as indications. Micromedics also has drug-drug interaction section, and I can also check IV compatibilities. Here are some links to sites for those who may want to become a certified technician, and this ends the online presentation.